Well, good morning, and welcome yet again to a wonderful Connected Health Symposium. My name is Denny Auciello. I'm the Chairman of Medicine Emeritus at Mass General Hospital and currently the Director of the Center for Assessment Technology and Continuous Health. We're all here today because we're entering an era, a dynamic era, in which our patients are at the center not only of partnerships in clinical care, but also of discovery. And as we unify wellness with the spirit of inquiry, there is nothing more important than to understand engagement. And indeed, today's talk is all about engagement. And one of the great joys I have this morning is to introduce to you one of our plenary lecturers, Don Berwick. Don is known, I'm sure, to all of you here. He is the President Emeritus and Senior Fellow at the Institute of Healthcare for Healthcare Improvement, of an organization that he founded and led for nearly 20 years. He, of course, has been an important leader in understanding healthcare delivery and the quality of healthcare, not only in this country but around the world, and has been honored from knighthood in the UK to our president anointing him to spearhead the changes that are absolutely necessary in assessing quality and delivering care in this country. Don, of course, comes to this activity with various credentials. I would posit that his most important one was the formative year he spent as my intern at Mass General Hospital. But my guess is that he would see that a little differently. In any case, it is a great pleasure today to have Don speak to us on perhaps the most important era we are entering in terms of American medicine, and certainly the tipping point as we begin to merge the patient-centric approach with quality and the likelihood of a much better healthcare delivery system. Don will be speaking us today on clinical leadership toward the triple aim. It's a real pleasure, and help me welcome Don Berwick.
Thanks. Thank you very much, Dennis. And yes, the year I spent with you was a real high point in my development. I very much value Dennis as a friend and colleague and mentor. And it's great to spend time with you. It looks like a wonderful symposium. I wish I could have been here more of the time. I want to talk a bit about where I think healthcare needs to head, and give you some ideas about the architecture of the healthcare system that you all want to build for the future. Let me begin with history, though. This is a bridge. I don't know if you've seen this picture before. It's the Choluteca River Bridge. It's in Honduras, the country of Honduras. It was built, as it says, in 1938. It was built by a very, very skilled bridge company. The American Bridge Company is the name. They built the Bronx Whitestone Bridge, and they were famous at the time for the quality of the bridges they built, which is important. You have to build very good bridges in Honduras because the weather's terrible. The bridge was tested to the maximum in 1995 when Hurricane Mitch, one of the worst hurricanes on record, hit Honduras. This is a part of Tegucigalpa, the capital city. Hurricane Mitch killed many people, and it destroyed many bridges. 150 bridges is the number I get off Wikipedia. But it didn't destroy the Choluteca River Bridge. The Choluteca River Bridge stood as designed, strong and proud. Just one problem: the river moved. So I'm told if you fly near Tegucigalpa today, you find a beautifully built bridge in the wrong place. This is American healthcare. It's a little unfair. That's a low blow because it's not exactly right. There's a river under the first bridge. The first bridge is technocracy. It's the audacity of modern biomedical medicine. It's hospitals. It's miracles. When I was in training, every kid I saw with acute lymphoblastic leukemia died. And now they all live, and they live because we had that first bridge. We could figure out how to deal with very, very difficult problems that affect, luckily, few of us. We couldn't transplant organs the way we can today when I was in training just a couple decades ago. So I don't want to deny the miracles. We need them, we need to keep them, and we need to keep growing the glory of the biotechnology of medicine that can produce such miracles. But that's not where the main river is. The river that I'm sure you've been talking about in this symposium, and that is where the need is today has a different structure. It's different names. It's not miracles. It's not audacity. It's not transplants. It's chronic illness care. It's reaching upstream to prevention. It's proper end-of-life care. It's addressing causes and burdens of illness over time and space that don't appear to us in events or episodes in which we dive in and rescue someone. It's where we support people through their journeys, through their lives. That bridge we have never built. We have to build it. That's where the costs are. That's where the needs are. That's where the rescue is for the American healthcare system as a whole, in my opinion. But it's difficult to build. It's a $2.6 trillion first bridge, more or less. And we have to figure out a way to build the second one, to have a healthcare system oriented toward health and prevention and chronic illness. That would be difficult under any circumstances, but circumstances are particularly tough right now because of the economy, because of the political discord that's kind of tearing our country apart because of these dramatic divides in rhetoric and public positions. The public's losing confidence in the ability to solve large problems, indeed, and you're not really seeing a major effort right now yet to build that second bridge. Nonetheless, it could be done. In my opinion, it's the right way to go. It's the way out. It's the way out of the mess. The mess is largely economic. It's healthcare taking so much resource from the rest of society that governments don't have money to support roads and infrastructure and museums and the safety net, so that laborers don't have the money to send their kids to college. And if you trace the cost structure problems in American healthcare, whether you're Republican or Democrat, no matter where you are on the political spectrum, they come back to healthcare. Building that second bridge, building the right way to address the needs of people with chronic illness over time and space to prevent illness is the way out for American healthcare, the American healthcare problem. It is true in other countries as well, by the way. The alternative to restructuring care is bad. It's cutting. The only other way we would have to get resources back to other social uses and private uses is to take things away from people, and I am not for that. I know a better way. The Institute for Healthcare Improvement, the organization that I led for 22 years and I'm senior fellow at now, developed the concept of the triple aim. The actual authors are two people you don't know, John Whittington from Peoria, Illinois, and Tom Nolan, a scholar in the world of improvement. Tom and John and I wrote this up in Health Affairs some 10 years ago. We suggested that the right definition of direction for the healthcare system's achievements would be a three-part aim, all connected. Better care, safe, effective, more patient-centered care, more oriented toward the needs of patients. Better health in populations, where we don't get sick in the first place because we're working upstream against heart attacks and strokes and depression and violence. And lower per capita cost. We are currently at about 17.6 or 17.7% of the GDP. Every piece of evidence I know would suggest that 15% of the GDP would be plenty, and most countries are doing just fine at 12. Better care, better health, and lower cost, achieved not through withholding things, but through developing a different healthcare system. We have one tool now in public policy in America, and that is the Affordable Care Act, Obamacare. Whether you like it or hate it, it is an attempt to move forward rather majestically toward the new situation. The situation would be, one, a situation of justice, where healthcare is a human right in America, which it is not at the moment. We're trying to make it that way. We're the only Western democracy that doesn't have healthcare for all. And because of that, a lot of the needs on that second river don't get met. So one thing this country is trying to do in public policy is get everybody in the tent. And the second is move the bridge, make all that sustainable by supporting the development of a system responsive to chronic illness, oriented to prevention, and keeping people at home. That's good news. It's good news that we're on a policy journey now, a dialogue in this country toward figuring out a way to have the healthcare system we want and need that can meet the needs of all. Is it possible? Well, this is the best news of all. It is possible. We actually know what it looks like. We know what that second bridge looked like. The reason we know is because it exists, not just in other countries where it can, but here in the US. Let me give you a couple of quick examples. This is my favorite. If you haven't studied it, you should. It's the Nucca system of care. I worked there. My wife had a sabbatical year in Anchorage, Alaska in the mid-1990s, and we moved the family there, and I saw patients in the Indian Health Service, the Alaska Native Health Service, which in the case of Nucca is run by a native corporation, South Central Foundation. So it's a native-owned, native-run healthcare system serving all the 60,000 natives in the Anchorage Bowl, the Alaska Natives. Nucca hadn't started then. It did in 2004. It is home-based, primary care-based, team-based, prevention-oriented care brought to full tilt. The aim in Nucca is to keep people home and well, using all of the resources of the community to do that, including spiritual healers. The whole idea in Nucca is to maintain wellness, self-sufficiency, and pride in the patient and family, who are, after all, the owners of the system. And it's a system in which the specialists seek to be idle. The hospitals seek to be empty. The transfer of power seeks to be to the home and hands of the patient and family. I just want to show you the Nucca results. You can study Nucca. They won the National Quality Award, the Malcolm Baldrige National Quality Award in 2009, and every June they have a full week in Anchorage. You can go up and study them. Do that. I suggest you ask your CEO for a ticket. Here are the Nucca results between 2004 and 2009. Emergency department visits down 50%. Hospital use down 53%. Specialist utilization down 65%. Primary care utilization down 20%. Enviable quality scores and the highest levels of satisfaction in patients, families, and staff that they've ever experienced. It's the triple aim. It's better care, better health, and lower cost, and it's done by building a care system that is metaphorically represented by that second bridge. They're covering the bridge, the river of prevention and chronic illness care. Here's another example. I know you're interested in technology at this conference. This is Dr. Sanjeev Arora. Dr. Arora is the man with a tie on at the end of the table. Dr. Arora is a liver specialist. He is especially skilled in management of hepatitis C, which, as you may know, is a very dangerous infection, but it can be cured. You can eradicate the virus, but it's very delicate to do that. You use highly toxic medicines, and it's a delicate enterprise. Before Dr. Arora took over this process at the University of New Mexico, if you wanted to get your hepatitis C cured, you went to the university. Now you don't have to. Dr. Arora has set up the ECHO project all over the state of New Mexico, using telemedicine interactions with primary care doctors and primary care nurses in little clinics in the entire state. He's teaching them not now just hepatitis C management, but also management of teen suicide, obesity prevention, asthma care, HIV/AIDS care, and on and on. The ECHO project runs all day long, capacitating the entire primary care system of New Mexico. And today, results published by Dr. Arora show the same or better levels of viral eradication for hepatitis C if you're a primary care nurse working in a rural clinic with a patient with Dr. Aurora's help than if you got to the University Medical Center. Same results, better care, better health, lower cost. He's doing it in prisons now with the same results. This is another example. This is the dental health aid therapy program. Remember, I saw kids in Alaska in the Bering Sea coast, little tiny villages, Scammon Bay and Hooper Bay. I would fly there to take care of the kids. I wouldn't have to do that today. Today they would have telemedicine in the clinic through electronic connections to the tertiary medical center in Anchorage. Travel down 70%, costs down, the return on investment 10.54 to 1, and to meet dental health needs, they're using dental health aid therapists. These are kids. They're kids just graduated from junior high school, junior college or high school, put into an 18-month training program. They're capable of getting on a little bush plane, flying to the villages all over Alaska with that pop-up robotic thing there. That's a dental workstation, and providing complete dental care, dental prophylaxis, caries treatment, minor restorations. They can meet all of the dental health needs of rural Alaska with 70 DHAT therapists, no dentists. This is innovation. This is innovation brought to full scale to build a system whose primary aim is to keep people home, well, out of the hospital, out of the technocracy, because they don't need the technocracy. The potential gains on the economic side are enormous. A properly run healthcare system addressing the real social needs, as represented in the triple aim, would be a lower cost system by far. My colleague at RAND Corporation, Andy Hackbarth, and I published a paper in JAMA in April of 2012 in which we simply made a rough estimate of the levels of wasted effort in healthcare given the absence of integrated, team-based, coordinated care like you see at Nucca. We estimated 6 categories of waste: overtreatment, doing things for people that they don't need; failures to coordinate care, that's not being Nucca, not having team-based care, so Mrs. Jones is bouncing in and out of the hospital; failures in care delivery, not being reliable; failures in administrative costs, where we just burden doctors and nurses and hospitals with real nonsense in terms of reporting systems and paper trails and things that make no sense at all; excess healthcare pricing, that's a competitive issue. We don't have competitive markets for commodities in healthcare; and fraud, theft, abuse. When Andy and I looked at the scientific literature and estimated the range of American healthcare costs invested in these forms of waste, our lowest estimate, if you just sum all the lowest estimates, that's 21% of the bill. If you sum the highest estimates, that's a scary 47% of the bill, 50% of healthcare waste. Our median estimate was 34%. That's $1 out of $3 going into one of these forms of wasted effort. The Institute of Medicine published a study 6 months later with different methods, same question. The study was called Best Care, Lower Cost. Independent of what Andy and I did, they made an estimate of the level of wasted effort in a healthcare system not oriented to need, and their estimate was 30%. It is the truth. 1 out of 3 American healthcare dollars, 1 out of 3 of $2.7 trillion, not meeting needs, not meeting anyone's needs. That's not producing miracles, that's just producing frustration. And it's emptying the wallets of people who do work, it's emptying the coffers of public treasuries that need that money for the safety net and other good works. The potential's enormous. A redesigned healthcare system would not only be better for the health of our nation, it would be lower cost. When the professional community, the country, finally embraces that mission, that idea, when it begins to go to the public and offer the triple aim, better care, better health, and lower cost, we will win the day. It will be the voice that's missing today, promising the country what it needs, a healthcare system that it can afford that better meets the needs of the population. Why wouldn't we just go there? How come, given what I've shown you about Nucca and the DHAT program and 10 or 20 other examples I could just go on if I had the time here today, why wouldn't we want it? Why wouldn't we want a system of lower cost and better outcome, given that we know what it looks like? We don't have to imagine it. Well, we would want it. I want it. You want it. In fact, I can't think of any rational person that wouldn't want Nucca-level care instead of cycling in and out of a hospital or being in an MRI machine they don't need. This is the problem. It's the transition problem. It's the crane up in the parking lot. It's the stranded capital of a healthcare system that built miracles. It's a labor force trained for an inpatient-oriented, acute care-oriented, episodically oriented care system when what we need is one oriented around communities and health and wellness. That's a major change. That's moving a ton of money from a $2.6 or $2.7 trillion enterprise into a new set of tasks and goals. We're seeing it start. We are seeing it start. The American Board of Internal Medicine Foundation has sponsored a wonderful project called Choosing Wisely, which I hope you've all looked at. Choosing Wisely is a challenge to 35 specialty societies in this country to identify one form of waste, overuse of processes and procedures that can't help, challenging those specialty societies to list publicly 5 overused resources or processes in their specialty. They've done it. You can get on the Choosing Wisely website and now see the physicians themselves at their own economic disadvantage, declaring what in their specialty is overused. It's an inkling, a beginning. I go around now the nation, hospital by hospital, listening to enlightened hospital leaders, and they're starting to think this way. They don't yet have the transition plan, but they will. They'll find it. They'll find the way to get from a system that celebrates full beds to one that celebrates empty beds. But understand for now that a hospital leader whose young doctor went to Nucca and came back and announced in the CEO's office in the boardroom, guess what, I found a way to reduce our hospital admissions 53% in 3 years, would not be embraced. The changes are afoot. We're seeing changes in payment systems, changes in public awareness, changes in some professional leadership, and I think breakthroughs among some progressive hospital systems, integrated systems of this country moving us in that direction. I could not overstate to you the crucial role the professionals have today in nurturing that change. It will not come from Washington. It will not come top down. It's going to have to come community by community. These are my guidelines for the second bridge, building the triple aim. The first is never, ever, ever hurt a patient. The concept that the only way we can get to sustainability in American healthcare is to take things away from people is simply wrong. It's wrong intellectually, scientifically, and morally. The proper way to orient care to be sustainable is exactly to orient it towards the needs of the public and the communities that we serve. The second is a moral commitment. It's to protect the disadvantaged. During this era of transition, when costs are pushed, our constraints are tight, the pain is high, the easiest people to take things away from are the poor, the disadvantaged, the disabled, people who are in the safety net system. And watch it happen around this country as Medicaid gets cut, as programs get attacked. We need professional leadership for the moral assertion that the first in line for the receipt of health care are people of disadvantage. The third is, I think, to stop thinking in terms of pilots. There is a horse race on today in our society between a plan for rescuing health care that takes things away and a plan that rescues health care by pursuing the triple aim with innovation. It's the second that we need, and there is no time to do it at small scale. It's going to have to be acts of courage on the part of professional groups and deliverers of care to say it's time to change for real, at scale. The fourth guideline is some way the hardest. It's that we cannot keep the money we save. The reduction of healthcare costs doesn't matter unless the recovered savings get returned to the people who pay. And there is only one source of payment for American healthcare. Let's be clear. Only one source of payment for American healthcare. That's the wages of laborers. No other source, whether it comes out of pocket or through taxes or through employer contributions, it's all coming out of the pockets of laborers. And so the key test of returning the money that we save is that the wages, the useful wages of people who go to work every day to protect their families go up, not down, and today they're going down. And the finally is, it's act locally. I wish we could, as an entire nation, move forward here. The Affordable Care Act is giving a chance to do that on the front of human justice. Healthcare is a human right. But on the tough job of building that second bridge, meeting the social need with our skills and technologies and will, that's going to happen, not as the nation as a whole. It's going to happen community by community. The opportunity for examples to develop, I showed you in Anchorage, Alaska at Nucca, it's open for everyone. It can be done at the community level, and I strongly urge that you take leadership in doing that. Thank you very much.